Good afternoon and welcome everybody to today's Rutgers NJ Health Division of Behavioral Health Services prep webinar. Today we're going to be covering the topic of cognitive impairment and treatment approaches within the inpatient population, and our special speaker today is Dr. Suzanne Roussel, psychologist from Trenton Psychiatric Hospital. So we're happy to have her with us today, and we're happy to have all of you with us. We'd like to remind you that this is an interactive training, and we encourage you to ask questions and participate throughout our session. And a recording of this webinar will be available after the presentation on our Rutgers SHPRI website listed below. And my colleague Jennifer Sperduto, also from the Rutgers SHPRI SPRI team, will load these links, any links that you might need after the webinar, into the chat as we go along. And we just need to read this little disclaimer, take care of some more housekeeping here. The Psychiatric Rehabilitation Educational Program is an online forum for a variety of topics relevant to the state psychiatric hospital staff. While Rutgers and DBHS are co-sponsors of this program, the prep webinars are peer presented, and as such, content is independently developed by the presenter each month. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. We'd also like to note that the recording in its entirety will be recorded so that you may view it later. If you missed a portion of this, or if you'd just like to rewatch it or share it with others. Also, if there's any of your peers who have not been able to attend, you can let them know that it's available on the SHPRI website. So we'd like to welcome Dr. Roussel, who's a clinical psychologist on the Kennedy Behavioral Support Unit at Trenton Psychiatric Hospital. She works primarily with those with intellectual disabilities, learning disabilities, and other neurological concerns. She has a PsyD from Chestnut Hill College with a concentration in psychological assessment, and it completed an APA accredited internship at Ancora. She also completed a 2-year postdoc fellowship in clinical neuropsych at Beechwood Neuro Rehab in Langhorne, Pennsylvania. And she's taught a variety of graduate and undergraduate topics in psychology. Her scholarly interests include the effects of psychopharmacology on neuropsychological test performance, ecological validity of neuropsychological testing, and personality disorders. So with that, I'd like to turn this over to Dr. Roussel.
Hi, everybody. Welcome. And as Dawn just stated, our presentation today is about the topic of cognitive impairment. So I wanted to introduce a poll to everyone. When you hear the word cognitive impairment, which of the following terms is the first thing that comes to your mind? Would you say it's autism, developmental delays, schizophrenia, or ADHD? So I'm just going to give the poll a minute to take place. So far, we're very far in the lead for developmental delays. We have a couple more people who are voting. I'll wait a few more moments for everyone to vote.
I ended the poll. They weren't trickling in anymore, Doc.
Okay, so 88% said that when you hear the word cognitive impairment, it makes you think of a developmental delays, which is kind of conceptualized as a congenital neurological disorder. A much fewer percentage, but still some said autism, some said ADHD, and a good few said schizophrenia. So the point that I want to make today, and again, this is a kind of a broad topic, and I wanted everyone to develop a basic understanding of what cognitive impairment is and how it can be rectified or treated in the inpatient setting. So, but the main point that I want to make today is cognitive impairment in the inpatient setting isn't just limited to those with developmental delays and other congenital neurological problems. It's really more of an impact of a wide variety of disorders that we're going to talk about today. And so recovery in the inpatient setting is really about, oh, I'm sorry, I forgot to share the result. So this would be the result of the poll if anyone didn't see it. Okay, so recovery in the inpatient setting for those with cognitive problems is really dependent upon a holistic approach to each individual patient. And it encompasses a variety of aspects, from focusing on wellness and focusing on spirituality to actually making a direct effort to remediate cognitive problems and utilizing sometimes a behavioral approach to address problem behaviors. So what we're going to talk about today is ideally going to give you a basic understanding of how cognitive impairment is present in a variety of illnesses. And we'll talk about how our treatment approach is to some of those things. I can't seem to get the poll off of my screen.
You should be able to just drag it down and then exit out.
I did, I got it, okay. Okay, so by the end of the webinar, hopefully you'll be able to identify the cognitive problems that we're talking about and some symptoms associated with the illnesses that commonly occur in an inpatient population. This is the next slide, please. Hopefully you'll be able to develop a general understanding of how behavior approaches can address challenging behaviors and describe the New Jersey State Health System's holistic approach to inpatient treatment. So let's look at some commonly understood definitions of what cognitive impairment actually is. You know, if you look at a dictionary definition, it describes it as a diminished functioning of capacity of conscious intellectual activity like thinking, reasoning, or remembering. So remember that memory is in there. The CDC, the Center for Disease Control, says that their cognitive impairment is problems with remembering new things, making decisions that affect your everyday life, otherwise known as adaptive functioning. The DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, which was published by the American Psychiatric Association, says that cognitive impairment encompasses a wide variety of areas like intellectual functioning, complex attention, learning and memory, language, perceptual motor stuff, the ability to socialize appropriately, executive functioning. And then finally, so the DSM actually breaks down, cognitive impairment being as a function of either neurodevelopmental or neurocognitive disorders. And neurodevelopmental disorders kind of exist as such because of the age, and manner of onset that they occur. And these neurodevelopmental disorders are broken down, when you're just thinking of intellectual disability as a neurodevelopmental disorder, they're broken down into, kind of level of severity based on IQ scores and adaptive functioning, into mild, moderate, severe, and profound. Next slide. So cognitive impairment usually comes as secondary to something else. It doesn't just exist for no reason on its own. As we know, traumatic brain injury can cause significant cognitive impairment, and we're going to get into that, how that is later. Seizure disorders, sometimes seizures are degenerative in nature and can cause impact on cognitive impairment with each seizure or just in general, and it can actually contribute to cognitive decline over time. A lot of congenital neurological deficits, which I mentioned there in parentheses, they're just an example of some rare congenital neurological issues. Autistic spectrum disorder can cause and come as a result of some cognitive impairment. that's genetically inherited, as can ADHD. Stroke, the kind of cognitive impairment you have as a result of a stroke is going to depend on where the stroke occurred and whether it was an actual infarct or an ischemia. So whether it was a total or partial blockage. Exposure to neurotoxins. There's neurotoxins everywhere in the environment. If you're exposed to a neurotoxin as a young child, very early on in life, you're going to have a lot of difficulty as you proceed with some kinds of neurotypical cognition. For example, exposure to lead. As an adult, exposure to pufferfish, exposure to a scorpion, exposure to aluminum or ingesting aluminum. These can all be neurotoxins that cause problems in a lot of different kinds of cognitive functions. Hypoxic injury or anoxic injury. Anything that has oxic at the end has to do with oxygen. So anytime the brain is deprived or limited on oxygen, that's likely for longer than like 3 to 5 minutes, it's going to cause some kind of injury and some kind of cognitive impairment. Whether or not it's lasting or not depends on why the person was anoxic or hypoxic, how long it lasted. It depends on a lot of factors, but it's likely to cause some kind of cognitive impairment. And also, as we know, dementia. Dementia can cause a lot of impairment in short-term memory, executive functioning, even language, ability to follow two-step commands, and that's a degenerative cognitive disorder that kind of occurs over time. Next slide, please. Okay, so you know how when you go to the mall and there's a map that says you are here? This is my you are here slide. So just so that everyone knows what we were talking about, this is just a general overview of the brain. I kind of wanted to make it user-friendly to everybody because some people find neuroanatomy and anatomy in general a snooze fest, but I'm going to try and make it as interesting as possible and as short as I can. So if you take a look at the little blue area here on the left, that is all considered the frontal lobe and the prefrontal cortex. Okay, the cortex is the outer kind of poofy, wrinkly part on the brain. Okay, and the outer prefrontal cortex is going to be responsible for your executive functioning. Some examples of executive functioning: attention, concentration, planning, organization, judgment, emotional control, working memory, impulsivity. These are all examples of what the prefrontal cortex is responsible for. How many people are sitting here right now looking at a messy desk? So my organizational skills may need some tweaking. I don't know about everyone else. So then let's move on to, let's go over to the right and go to the left temporoparietal cortex. That would be this greenish area here that you see. It's not present in the second diagram, in the diagram on the lower left, but it is present on the upper left. And that is the left temporoparietal cortex, and that's going to be responsible for a lot of language functioning, particularly receptive and expressive language. Socio-emotional function, that has to do with a lot of different brain areas. Socio-emotional functioning has to do with how emotionally labile the person is. Whether they are kind of even keel with their emotions or they're kind of back and forth. Overall emotional and personality functioning, as well as interactions with others and kind of mirroring and picking up on social cues. There's a wide variety of brain areas associated with that, too many to list. The next one down to general intellectual functioning. Again, that's some various brain areas. It's all areas of the brain, and particularly the cortex working together, to help the person function intellectually. And intellectual functioning, as it's measured by standardized tests, typically encompasses verbal knowledge and reasoning, perceptual reasoning, working memory, visual processing speed, and some aspect of reasoning, some aspect of verbal reasoning also. Visuospatial, that's going to have to do with the occipital cortex as well as the motor cortex and parietal, because a lot of times visual processing doesn't depend solely on the eyes and the occipital lobe. It depends on motor integration as well. So the back here, this little purple area, is going to be the occipital cortex, with some integration from the motor cortex and other areas responsible for motor coordination, and a bit of the parietal cortex as well, which also has something to do with an understanding of spatial perception, along with the cerebellum. So gross and fine motor is the next one over. Gross and fine motor skills, again, prefrontal motor cortex and other areas, including the parietal lobe and the cerebellum, integrate to kind of deal with gross and fine motor movements. There are many people who are delayed in certain areas, and they have problems with writing. They have problems with their grasp. They still have a grasp that is conceptualized as being similar to a grasp of, maybe an 8-year-old or a 9-year-old, and they have problems writing. There's some people that have problems, problematic gaits due to different issues that have occurred in their life. But it's considered an overview or an area of consideration when looking at someone's overall functioning level and level of cognitive impairment. And then finally, we have memory. Memory consists of long-term memory, working memory, procedural memory, and there's other more specific types. Procedural memory is kind of the memory of how to do something. So if you think about like tying your shoes, how do we remember how to tie our shoes every day? It's called procedural memory. Visual and verbal memory. Visual memory is memory for stuff that you see. Verbal memory or auditory memory is stuff that you hear. That's why we remember things when they're presented most often, most visually and verbally. So the point of the overview is to kind of understand the different areas of patients' cognitive functioning. And here we are. Okay. So now we're going to talk a little bit about some of the common neurodevelopmental and neurocognitive disorders that we can come across while we're working in the state hospital system. Again, so we talked a little bit about a few neurodevelopmental disorders. We'll get into it a little bit later. Neurodevelopmental disorders have to do with the age and manner of onset. So they tend to occur earlier in life, or kind of start their progression or their course earlier in life, or even prenatally, and progress throughout the lifespan. Neurocognitive disorders start kind of later in life, and may or may not progress as they continue. Neurocognitive disorders are things like traumatic brain injury and dementia. They're both considered neurocognitive disorders, not neurodevelopmental. So speaking of brain injury, we will start with that. We will start by talking about traumatic brain injury and what that looks like. Traumatic brain injury versus acquired brain injury occurs as a result of a blow to the head. So it's usually occurred by a car accident, or being hit in the head with something sharp, or a fall, or something of that nature. An acquired brain injury is still an injury, but it's incurred via something like anoxia, exposure to a neurotoxin, or a birth injury. It's said that people with cerebral palsy who have cerebral palsy as a result of a birth injury have what's called an acquired brain injury, or ABI. But today we're going to be talking more about traumatic brain injury. So what happens is this blunt object, whether it be the result of a fall or an accident or a shooting or something, this blunt object hits the head and penetrates the outer layers of the skull and does something to the brain. I'm going to respond to questions and comments in just a moment. Let me just get this through this part. But what happens is when it hits the outer skull and the brain, it can cause something called axon shearing. You see this little guy up in the upper left corner of the slide? That is a neuron. That is a brain cell. And there are millions and millions of neurons in our brain and spinal cord that make up our nervous system. That's in fact what all of the tissue is made up of. These axons, which is these little tails, and the dendrites and the somas of all of these neurons. So when you have axon shearing, If you have an injury to a part of your brain, there's an influx of calcium ions to kind of aid the brain with healing, right? So that can cause this axon to actually swell and break off. And that can be the cause of the axon shearing. And if these axons break off, it damages the connections in other areas of the brain. So people end up having a loss of function or a loss of something depending on where the injury occurs. In addition to the loss of in addition to the axon shearing, what can also happen is excessive swelling, which I just talked about, which can lead to the axon shearing, and something called apoptosis, which is actually called programmed cell death. So it's like a little tiny ticking time bomb in these neurons that can go off if there's an injury. So the cell is kind of already set to die, kind of like a suicide bomber, right? It's already set to die. It's just a matter of when. When the time bomb goes off, that's when the cell dies. And these together can cause a lot of widespread cell death across different areas of the brain, depending on where and how the injury occurred. The other thing I wanted to mention that can cause axon shearing is something called coup contra coup. It's a French word, and it kind of means back and forth, right? Our brain sits in our skull, and the frontal lobe part in particular sits on a bony ridge that exists in our skull, like right about here, right? And when you get into an accident, think about it, when you're in a car accident, you're kind of thrown forward, right, and back, or side to side. And your brain kind of sloshes around in its little shelf there. And this bony ridge in our skull can scrape against the neurons on the underside of the frontal lobe, causing definite impairment, causing that axon shearing that I was just talking about. When you sever connections among neurons, they can be rebuilt, but they don't quite look the same as they did before. So people can relearn to walk, people can relearn to read, people can improve their memory, people can improve all different things about their functioning, but it doesn't quite look the same. So these connections may be rebuilt, but they may not be connected the same way they were before. And TBI also increases susceptibility at a later age to dementia or early onset dementia, depending on when the age occurs. Early onset dementia is any dementia that occurs, kind of before the age of 60. Dementia that occurs 65 and over is considered an appropriate time for it, if there is an appropriate time. But yeah, any kind of injury can increase susceptibility to dementia. They actually found that when they did postmortem studies of boxers and their time in the ring, and how the dementia processes, how far along the dementia processes were when these boxers were fighting their whole life, and after they died, they took apart their brains and they looked and they saw the dementia processes were pretty far along. So I'm going to pause really quick because I think there were a couple of questions and comments in the chat.
Yeah, so Nicole had said that her father suffers from later stage vascular dementia, and she's witnessed that progression of his neurocognitive issues firsthand, which is.
Yes, I'm sorry to hear that.
Yeah.
Thank you for sharing.
And then
and someone said shaken baby syndrome, and yes, in infants, when the coup contra coup definitely occurs as a result of shaken baby syndrome, but the only problem with that is more life-threatening is the actual brain stem is kind of strained in that, because the baby's head, they don't have the muscle structure to support their neck yet. So the actual shaking of their kind of floppy head can really damage their brain stem, and that's kind of, unfortunately, in shaken baby syndrome, what can cause a lot of impairment and even death. Okay, so that was traumatic brain injury. Let's look at the next. Some statistics, I threw these out there in case people wanted to know. In 2019, there were about 223,000 TBI-related hospitalizations and about 64,000 deaths related to TBI. People aged 75 and older had the highest numbers of TBI-related hospitalization and deaths. And males were 2 times more likely to be hospitalized and 3 times more likely to die a TBI-related death than females. So those are just a couple of statistics from the CDC. So I have a question. What is the most common cause of traumatic brain injury in the United States? Let's see who knows. Ooh, I think people got this one. Okay. So the answer to that is everyone's 52% said falls, and you are correct. Falls are the leading cause of traumatic brain injury, followed by car accidents. Nobody said knife wounds. I kind of threw that in as a distractor item. I didn't think anyone would say that. But yes, it is actually falls. So good. Everybody knows that. Okay. So cognitive impairments that co-occur as a result of traumatic brain injury. Most definitely executive functioning impairments, which we talked about: planning, organization, judgment, memory. Well, memory is its own function, but it's at the back of the frontal lobe, the beginning of the parietal lobe. Seizures, increased risk of dementia and stroke, other impairments, depending what brain injury area was injured and whether the injury was more focal or diffuse. So a focal injury means it was injured acutely and the injury existed in kind of one area. A diffuse injury is more widespread. A lot of times socio-emotional functioning is impacted due to alexithymia. Alexithymia is when you have an impairment and you have no idea that you have that impairment. And unfortunately, the people around you see it and you kind of don't know it. So you don't understand why people may be drifting away from you, or the quality of your social interactions aren't what they were, or people aren't, don't want to be friends with you anymore. Your partner divorces you or separates from you. So there's a lot of impairment to social emotional functioning and a lot of depression as a result of these fading connections to other people. And then also more depression when someone realizes that, hey, I cannot function the way that I used to. What do I do now? So there is a lot of depression associated with traumatic brain injury for those reasons. Next slide, please. ADHD. This is another one we commonly see in the hospital setting. Many of our patients have ADHD. It may be superimposed on other things, and it may be hard to tease apart from other things, but many of them have some kind of ADHD or attention problems. Research has shown that there is structural and functional differences in brain anatomy in patients with ADHD when compared to patients without. Some psychostimulants or pseudostimulants help to normalize brain functions. Your brain is made up of gray and white matter, and the outside, the cerebral cortex, that wrinkly, poofy area that I showed you, that's considered the gray matter. And so there's decreased total matter volume. So the poofs aren't as poofy in the cerebral cortex. And there are some subcortical or midbrain abnormalities. There's also some smaller midbrain structures in the person with ADHD, and they may shrink or get a little bit smaller as they age. And then there are problems in the prefrontal cortex. The main issue in people with ADHD is their executive function. They may have problems paying attention. They may have problems listening. They may have problems organizing. It depends what type of ADHD they have, or if it's a combination of the two types. But yes, problems in the prefrontal cortex, the striatum, which is responsible for the reward system in the body and the brain, and some motor stuff. The basal ganglia, which is responsible for movement, behavior, emotions, along with executive functioning, and the cerebellum, which is responsible in part with the parietal lobe for balance coordination, posture, and some eye movements. So it said that everyone, or the people with ADHD, can have problems in those areas. Next slide, please. So cognitive impairments, like I said, with ADHD, executive functioning is the main one. Issues with planning, organization, judgment of whether something is a good idea to do or not, or how much a person can take on their plate, in a workplace situation or even in a school situation. Regulating your emotions. You may feel overwhelmed by intense emotions if you have ADHD. Controlling impulses. There are two primary types of ADHD, which is inattentive type and hyperactive type, and then there's also the combined presentation. People with the inattentive presentation have a lot of difficulty just paying attention to tasks, both visually and auditorily, and they can have a tendency to daydream a little bit, especially if they're dealing with a topic that's not interesting to them. Next slide, please. I don't think I talked about hyperactive types of ADHD. I'm sorry, if I can go back one again. I don't think I mentioned the hyperactive ADHD type. That is, presented by a lot of fidgeting, inability to sit still in class or at work. Maybe like starting a bunch of things and not finishing them, and that's all related to executive functioning and difficulty with organization. And then you have some combined features of both, where you have some factors that come in from the inattention aspect and some that come in from the hyperactive type. Okay, next slide, please. So cognitive impairments and schizophrenia. Obviously, we know that schizophrenia is something that we see in the hospital setting. Schizophrenia is also marked by noteworthy cognitive impairments. And this is what I meant. It doesn't just exist in people with developmental delays or intellectual disability. It exists in others too. There may be people with schizophrenia who have a perfectly average IQ and still have problems with reasoning and problem solving and thinking in the abstract, thinking about things that aren't tangible. They may also have problems with executive functioning, social functioning, and visual and verbal learning. The reasons behind that may be different than someone with a traumatic brain injury or a neurodevelopmental disorder, but the impact can still be very grave. Cognitive decline is being considered more often as a key characteristic of schizophrenia. Research has stated that. The abnormal brain development of someone with schizophrenia actually begins prenatally in utero and continues to proceed throughout childhood development. The stage when a child is developing schizophrenia or another psychotic disorder is considered the prodromal phase. And that can often be seen in, maybe early, in women, maybe like early to mid adolescence, and in men, maybe mid to late adolescence, kind of right before the onset of the acute symptoms. There are abnormalities in people with schizophrenia in many brain areas. There are changes in their neuroplasticity as they age, which means their ability to form and develop and create new neural connections. And there's also problems in their neuronal maturation, so how their neurons develop over time. In addition to the organic changes that can occur with people with schizophrenia, antipsychotics that people take, antipsychotic medication that people take for schizophrenia also significantly can slow processing speed and can also have some impact on the motor components due to how it acts on acetylcholine. Next slide, please. Okay, cognitive impairment in bipolar disorder. As we know, bipolar disorder can exist in three phases. We have the depressed phase, we have the manic or hypomanic phase, or we have the euthymic phase when the person is neither depressed nor manic or hypomanic. Different cognitive impairments occur at different phases of the illness. And the reason for this is it's suspected that very recent research has suspected that there are actual differences in cortical thickness. So thicknesses of that wrinkly, poofy part of the brain in different brain areas that vary slightly very tiny bits throughout the different phases of the bipolar disorder. And it's suspected that it's the brain's way of temporarily compensating for its deficits during that stage. Recent research about neuropsych testing and using functional MRI imaging says that the brains of those with bipolar disorder have difficulty suppressing activity in some areas, and they have a hard time activating and integrating brain areas needed to work on the task. So they have a hard time shutting down some brain areas that they don't need to perform a task, and then activating and getting to join together other areas that they do need to work on the task. So they have difficulty with that. During the depressed phase of the bipolar disorder cycle, people may have difficulties with attention and concentration, working memory, and just an overall decrease in brain function processes. During a manic or hypomanic phase, they may have poorer verbal memory and a decline in those executive functionings that I keep talking about. And actually a kind of sharp decline in executive functions may predict an approaching onset of a manic or hypomanic episode. So I thought that was interesting because I didn't know that before. And then during the euthymic phase, the cognitive impairments that existed in the other two phases were present, maybe to a lesser degree, but they were still present. And general performance on tests of intellectual functioning in those who've been diagnosed with bipolar disorder, even if they're in a euthymic phase, is kind of lower across the board than people who have not been diagnosed with bipolar disorder. Okay, so next slide.
Before we move on to the poll, can I just throw something out there? Can you speak a little bit to the idea of, obviously there are so many layers to cognitive impairments and where they come from, whether it's a response to medication, like there's so many different factors. How do you, one, differentiate, or two, does it matter if you differentiate where the actual impairment comes from or how it, where it stems from in terms of treating it or responding to it?
So I think that the differentiation aspect depends on getting a really good history and really getting to understand and know the patient. Getting the patient talking about any kind of experiences that they had that may have impacted their cognitive functioning. For example, I ask every single patient that I meet, have you ever been in a car accident or did you ever fall and hit your head? And if they say yes, I say, oh yeah? Well, did you lose consciousness? Well, what does that mean? Well, were you knocked out? Did you see stars? Oh yeah, I was in the hospital for a week. Okay, well then that's going to tell me something, that there's a problem that is probably existing from an exact point in time. If the patient is a poor historian or doesn't remember and appears to have symptoms of an acute psychosis, then kind of getting to know the patient over time and kind of gently teasing apart whether the impairment comes from a psychosis or an organic brain deficiency, that takes time. It takes neuropsychological testing, maybe some neurology consulting. There's a lot of different ways, but I would say the best place to start is to try the best you can to get a good history and get to know the patient really, really well.
Great, thank you.
Which brings me to my poll. I had 3 polls in here. I know I went poll happy, but I really like to know what people think. So what is the most important aspect of a patient's treatment? I'm loving where this is going. Okay, so it appears that 67% said the therapeutic relationship, and that would be correct. And some might say, no, this is a matter of opinion. No, it's not. This isn't up for debate. The most important aspect of a patient's treatment is the therapeutic relationship. setting appropriate goals is absolutely important. I'm going to give a nod to the 23% of you that said that setting appropriate goals was the most important aspect of a patient's treatment. Yes, it is important to have guidelines for where you're going in treatment. But the absolute most important aspect of a patient's treatment is the therapeutic relationship. Because, and I wanted to share this quote because I loved it and it applies to the presentation today. Go to the next slide. People will not always remember what you said, but they will always remember how you made them feel. So a patient may not remember things that you taught them. They may not remember that they have to work on, X, Y, and Z goal. They may not remember that they have court on Wednesday. They may not remember that they have to not be aggressive to anybody so that they can work toward discharge. But they will remember that one person that sat with them and, talked about their family, or sat with them and had a genuine conversation, or shared a good moment with them. They may not remember all aspects of their treatment. They may not remember their medications, but they will remember the people that made them feel worthwhile. So above all, because there are so many issues and so many areas in these disorders that kind of highlight the fact that patients have memory impairment, the focus on this is really, really important. And if you do nothing else for them, being present with them and being with them is of utmost importance. So that being said, we in the state hospital system use a very holistic approach to treatment of patients with cognitive impairment, which again, I hope that everybody's gotten the point by now. Anybody who is inpatient and has any of the aforementioned disorders, or maybe even any other disorders, has some kind of cognitive impairment, or likely has some kind of cognitive impairment. So going into treatment with the idea that this may be a thing is a really, really good idea. Which is why the holistic approach, or the focus on the whole patient or the whole person throughout their experience here, is a good idea. The fact that we have wellness groups, music and art therapy. I cannot express how valuable music and art therapy is, because of the difficulties that a lot of patients have, especially those with cognitive impairment, the difficulty that these patients have expressing themselves in words is significant. So if they can express themselves in another way and still obtain that catharsis and have that experience of bonding with someone through another medium, then that's great. The focus on spirituality. Sometimes when you're down really low, you really need to remember that there's something outside of oneself that exists. There's something bigger than you and I that exists. And that's why the focus on spirituality is important also. In addition to our substance abuse treatment, our medication, and our emphasis on health maintenance. Somebody said, say it louder for the folks in the back.
That was for the therapy part.
The therapy part? Okay.
Yeah, the music therapy. And Barbara Stern said the holistic approach is most important. Thanks for validating that.
Yeah, no, absolutely. I think the holistic approach is important. I mean, above all else. So at TPH, we have a positive behavior support unit, and our positive behavior support unit focuses on the reinforcement of positive, appropriate, adaptive, and recovery-oriented behaviors. We also have cognitive remediation, which is a program designed to help patients practice utilizing cognitive skills that may have been weakened, lost, or damaged. It is said that people that practice these skills can at least regain some level of functioning in these areas, and it can kind of support their overall sense of well-being, their overall sense of self-efficacy, and their ability to sustain some attention, and maybe even improve processing speed. So let's see. So next slide, please. We'll talk about positive behavior support first. Again, the most important part of this is getting to know the patient and developing a therapeutic relationship with them. Classic behaviorist approaches do not include a therapeutic alliance as an aspect that I know of, but it is important for positive behavior support in the state hospital setting. And so getting to know the patient and developing a therapeutic relationship with them, understanding kind of what makes them tick and knowing why they behave the way that they do. You know, if somebody throws chairs every single day at 3 p.m., you know, it might not just because that's when they feel like throwing chairs. It's probably because something in that environment is triggering it. Or they have gotten reinforced somehow, and we'll talk about that in a second. They've gotten reinforced somehow for doing that, so they're more likely to repeat the behavior. Positive behavior support is based on the idea that the more likely, the more the person is positively reinforced or given something they like after doing a behavior, they're more likely to do that behavior again. So if we're reinforcing the right things, like, you know, getting up in the morning, brushing your teeth, attending to your hygiene ritual, going to groups, maintaining non-aggression, maintaining a lack of self-injurious behavior, and that person is rewarded for those things, they're more likely to keep doing that. So rewarding the patient for that is about finding a reinforcer that is most pleasing to them. If I do something that you want me to do and you give me a piece of cake, it's not going to mean much, because you know why? I don't like cake that much. I like ice cream. I'm a big ice cream person. So if I do something and you give me an ice cream sundae, I'm probably really, really more likely to do that thing that you want me to do than I would be if you gave me cake. How this works on the positive behavior support unit is that the patients can accrue points throughout the day that they cash in at the end of the day for a reward of some sort. These rewards consist of both primary and secondary reinforcers. Primary reinforcer is something like that satisfies a biological need, like food. A secondary reinforcer is something like something tangible that doesn't satisfy a biological need, but is pleasurable nonetheless. You know, we have crossword puzzles, coloring books, cute slipper socks, hygiene products, what have you. Okay, so the other thing I wanted to mention is cognitive remediation. That is the games or programs that we have that helps the patient practice these cognitive skills. It's offered in a computer program format, but it can also be done when you don't have a computer. A lot of times our unit has been on quarantine, so I have gone to the unit and offered the CogRem group, and it's valuable for patients with cognitive impairments, you know, of all sorts. And it has actually been used and is being used in the state hospital system to help patients become restored to competency to stand trial. This has been demonstrated in research to be of a key aspect of helping the patient recover some kind of cognitive functioning that does help them return to competency. So some examples, next slide, please, of some in-person cognitive remediation strategies. I'm going to show you. I'm going to give you a little, just a tiny, quick show of our program that we use in a moment. But some in-person cognitive remediation activities are on the unit or exercises that practice their executive functioning. You know, helping, you know, if I would go to the unit and I'd say, so we're going to plan a party. What do we need to do? And the patients would say, we'll get some food. Well, what kind of food do you want? And they would make lists of the kind of food that they would want to order, the guests that they would want to invite. You know, do they need to clean the house? Do they, you know, they would make a kind of list and prioritize that. That works their executive functioning. We would do visual and spatial exercises like picture completion tasks and, you know, which one of these things is not like the other. We would do processing speed worksheets, you know, a page of printed capital M's and lowercase m's, and they would have to cross out all the capital M's as quickly as they could. And then also some imagined exposure to real life situations, like, you know, if you lived by yourself and you lived in your own apartment and the fire alarm went off, what would you do? Oh, I'd call 911 or I'd put the fire out. Well, what about getting out of the apartment? So we would talk about the importance of that and kind of go through the real life situations. I'm going to go to the next slide. The program that we actually use is called Happy Neuron. And I am going to go there and I'm going to try to share my screen. I think this program is used at both Ann Klein and at TPH. I'm not really sure if any of the other hospitals use it. Okay. I'm just going to show you briefly. I'm going to share my screen.
We saw it for a second.
You saw, okay, yeah. So my microphone became disabled when I went to share my screen. I'm going to try and do it again and do it the way that we discussed.
Yeah.
All right. So I need to share. Is it the entire screen?
The entire screen, and then click the audio.
And then click share system
Right.
audio?
Yes.
I thought that was how I did it. So for some reason, when I share, I have to maybe uncheck that, because when I share my screen, it's not working out if I click that. So let me try this way. Okay, can everyone hear me?
We can hear
Yes.
you, but we don't see the happy neuron. There we go.
Okay,
There
you
we
see
go.
it now? Okay.
Yep, good.
Okay, so here it is. This is our Happy Neuron website. This is what we use, and this is an example of some of the games that the patients play. They each, go to the computer, and I can log in and prescribe a series of games for them to play that might kind of sharpen their cognitive skills. I will show you one now. One of the most common ones that I kind of start with that's easy and also gets them acclimated to using the mouse is called Catch the Ladybug. So what they have to do is they have to look at the screen, and they have to click the mouse on their ladybug as quick as possible before it disappears. So they would kind of go through this process, and the shadow is showing them where it's going to appear next. So the patients would kind of go through this a few times. Everybody likes this game, whether they're highly intelligent or they have some impairment. Everybody likes this game, and for some reason, it kind of encourages a lot of team approaches to encourage people to catch the ladybugs. But yeah, this is just an example of processing speed. You can see they have the games grouped according to what cognitive function it targets. So here's some stuff for auditory attention and memory and processing. There's some processing speed, visual attention, visual and spatial abilities, spatial memory. Let me tell you, some of these visual and spatial, I have crappy spatial ability, and these patients really know, Dr. R, it goes like this. They really know what they're doing when it comes to spatial stuff, and I like watching them use their skills. Visual memory, verbal memory, reasoning. The reasoning ones are kind of difficult for a lot of our patients, but not all of them. This Modulo is a recently added game. I'm not even going to show it to you because I'm not going to lie. I cannot figure out how to apply the rules to the puzzle, but it's just understand that it's a puzzle. And some of these actually mimic some standard neuropsychological tests, like the Tower of Hanoi. Those who have a neuropsychological or neurological background understand what that's about. And the Hooray for Change mimics the trail making test on the Halsted right-hand neuropsychological battery. There's also one that I'm told by the patients mimics Wheel of Fortune. So this one they have to solve a quote by using letters that are assigned to symbols, and they have to figure out what letter goes where. So that's just a really brief overview of Happy Neuron. And so I wanted to know, does anyone have any questions? We are kind of at the end of our presentation, and I wanted to know if anyone has any questions or comments.
Feel free to type any questions, or you can raise your hand on the Zoom list, and I can unmute your mic if you have any questions. While you're thinking of questions, I'm going to post the link to the training evaluation, which also has a link to download the handouts, the slides, all the resources that Dr. Roussel mentioned, and you can also print a certificate of attendance and completion from there.
I also wanted to give a shout out to my internship alma mater, Ancora. If anybody's attending from Ancora, hi, and it is nice to know that you're here. And yeah, thank you everybody so much for attending. Please feel free, if you have any questions or thoughts or anything, you can email me. This is a list of my resources. The Thinking Skills Workbook, when I do my groups, my CogRen groups on the unit, this is it. I don't know if you can see it.
No, put it in front of your face.
I did. It
No,
blends it. Anyways, you can look it up. The Thinking Skills Workbook that has some good worksheets in it for CogRem. Oh, somebody's asking, is ADHD and executive functioning hereditary? So ADHD does have a hereditary component. In addition to any kind of prenatal substance use can exacerbate the predisposition to ADHD if there's some kind of mental illness that already exists in the family. Yes. So it's a little bit of both. Someone said, do you use food as a reinforcement item for morbidly obese and or diabetic patients? Thanks for any comments. So our wonderful psychiatrist and dietitian has recently revamped the food snack reinforcement to include a wide variety of really yummy, healthy options. So yes, it is used as a reinforcement item for people that are obese or diabetic, but they have a lot of other options, and I believe their diets are monitored to include that snack. It doesn't have to necessarily be, an entire bag of potato chips, but it might be like 100-calorie bag. So yeah, it's overseen by dietary and definitely by medical doctors. Thank you for your questions. I appreciate that.
There was another question about facial recognition real quick.
Let me see if I can see it.
What about facial recognition? Is this done at the hospital? Oh, recognition. Is that facial?
I'm sorry, I don't see the question.
It's up a little bit higher. It says, what about facial recognition practice? Is this done at the hospital?
Yes. Facial recognition is a very specific brain area. It's called the fusiform gyrus. It is in the bottom underside of the occipital lobe. It's a very specific brain area. But yes, one of the games that I covered deals with facial recognition, helping someone practice facial recognition. So yes, that is part of it. Anyone have any more?
Also, the Happy Neuron website, there's a link to it that people can go to. You need a subscription, but I believe you mentioned that there was a free trial, like you could look at it.
Yeah, if you put your email in, they'll email you some worksheets to try out, and I believe it'll let you try a demo.
Great.
Okay, well, thank you everybody for attending today. I hope that you found the presentation to be informative, and if you have any questions, you can absolutely email me or contact me, and yeah, enjoy the rest of your day.
Thank you so much.
Thank you, Dr. Roussel.
Somebody said, so these exercises will help ADHD. Yeah, ideally, the cognitive remediation program, what works is if you have a neuropsychologist kind of set up the exercises that would probably work best for you, and you review them with that person periodically to check your progress. But yeah, these exercises can provide some assistance with different aspects of cognitive functions or cognitive impairments related to ADHD.
Well, we wanted to thank Dr. Roussel for making herself available today and all the hard work she's put into this presentation over the last month. And I know I found it helpful and have learned something over a lot of things over the last month. And I really thank you for the "you are here" diagram of the brain, because that's going to help me out. So thank you for that. And if there are any other questions, we could stay for a minute or two, but not much longer. Please feel free to pop them into the chat. And otherwise, we hope you all have a wonderful evening and a safe week. Thank you for attending.
So somebody's asking for the slide, the 1 page per slide presentation.
Vivian, can you send an, you know what, I'm gonna just get your email and I will send it to you directly. Okay.
Thank you, everyone. Have a great evening.
Thank you.